Entonces, para nuestra segunda conferencia le damos la bienvenida a un primerizo en tierras chilenas, Vice-Chairman del Departamento de Medicina de Urgencias, Associate Chief Medical Officer del Health Science Center de la Universidad de Stony Brook, Nueva York. Un fuerte aplauso para el doctor Peter VICCELLIO, que está preparando su presentación. Él nos va a hablar de Esto está lleno, colapso en el servicio de urgencias.
Momento. Okay, I think it should work.
Let me just
press there.
that should do it.
Got it. All right.
Voila. I need the mic.
And then
Da, da, da. La 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 la. Okay, good. Hablo español perfectamente, pero solo poquito. So I'm going to do this in English. Do any of you have problems here with crowding in your emergency departments? See, no? Okay, thank you very much. So this is a struggle that we have had in the United States. For how long have we had it? This is me now, and this is me when it started. So that's about 2 centuries worth of problem with crowding. Now, emergency medicine is relatively new in Chile compared to the United States. So you're in your political beginnings where you're going to start working with your administration, with public health department, with legislature to have your impact and your say on the future. And because of that, there's a lot of pressure on you to make sure that you do things correctly, say things correctly. And so I wanted to offer a little advice to you for your future careers so that you don't get eaten alive. So I don't have the sound on this, so I'll just read the words out for the translator. But it says this, and this is a good advice to you when you need to go and meet with an administrator, with a legislator or public health. Do you have feelings of inadequacy? Do you suffer from shyness? Do you sometimes wish you were more assertive? If you said yes to any of these questions, ask your doctor or pharmacist about tequila. So I want to sort of go through what we know about the causes of crowding, what the consequences are, and then what some of the possible solutions may be. And I'm going to spend just very briefly on the cause. There's a lot of finger pointing. And when we can't solve the problem, we usually point the finger toward the person that's not in the room. And the person that's not in the room is the patient. So it's all the patient's fault. How many people here see patients who come to the emergency department that don't need to be there? Okay, so let me ask a question. How many of you feel that someone with a sore throat should come to the emergency department? Okay, a couple. How many of you feel that a strep throat should come to the emergency department? How many of you feel a peritonsillar abscess should come to the emergency department? Epiglottitis. Retropharyngeal abscess that's about to obstruct the airway. What do all of those patients have? They have pain in their throat. So what you have just declared is a patient at home is able to do a differential diagnosis of their throat pain. No, I'm okay, I can stay at home. So for almost every symptom that you want to mention, from thumb pain to throat pain to chest pain to belly pain, it's very difficult for the patient to pick it out. There was a wonderful study that was done by Dr. Franasek in Michigan, and he did the following study. When patients showed up, he asked the patient, do you feel like you're having an absolute emergency or something that needs to be taken care of today, or it could really wait for till next week? And then he asked the doctor the same thing. And of the patients that the doctor said, this person's having an absolute emergency, 25% of those patients thought that they had a routine problem that could be seen in a week. So what we know for sure is that the population of people is unable to pick out whether or not they're having a true emergency or not. So any way of obstructing visits to the emergency department also obstructs people who are having true emergencies. But the most important thing is you can't fix that. So if you're having trouble with crowding, why waste your time on that effort? So let's, how many of you have gone to the emergency department in the last 5 years? So so actually in the United States, probably about 50% of the people would have raised their hand. 50% of the people that believe that people go to the emergency department too much would have raised their hand and said, yes, I've been there myself. What concerns me about this group is most of you say you haven't been to the emergency department, but you work there. So I hope you are actually going there as a doctor. I'm not going to talk about how well you run your emergency department and whether that might be the cause of people waiting for 4 or 5 hours to be seen. That's a whole separate issue. So I'm going to assume that you've adopted the basic principles of what you need to do to properly run an emergency department. And if you have, and you're still crowded, most of the studies on this in the United States have shown that the biggest cause of crowding is from admitted patients that have no beds. They can't go upstairs, so they get stuck in the emergency department. And they get stuck in the emergency department with the wrong people, the wrong staff, not enough space. And what do we do about that? So this is my emergency department, and we have people laying all over the place. This is from Mexico, I think, people laying all over the place. So one of the solutions is let's build a bigger emergency department. And this is what's been found in multiple studies. Let's say I average 10 boarders, 10 patients that sit in my emergency department that have no beds upstairs. So let's build 10 more beds for my emergency department. And look a year from now, what do you see? I'm now holding 20 patients instead of 10. So it doesn't solve anything to do that. So that's the wrong solution. This is more pictures of my emergency department. As you can see, we do have a little bit of crowding here. The other solution is let's build more beds upstairs. I don't know what the finances are here for doing this, but in the United States, if I want to add a bed, it costs about $1 million in New York to add a bed. In California, it costs about $1.6 million to add it. Once you have that additional bed, in the United States, it costs in New York $600,000 a year to staff it, and in California, it costs $1 million a year to staff it. So if that's the only way you can solve this problem, it's an extraordinarily expensive way of doing it. So let's talk about some of the consequences of boarding. There's a lot of literature to support what I'm about to say. I'm not going to show you the literature for the sake of time. The first thing is that long waits lead to sicker patients. Is the person that had the pneumonia now has acute respiratory failure. The person that has pyelonephritis now has sepsis. So there's significant consequences from these waits. From in multiple studies in the States, if a patient sits in the emergency department because there's no bed, their overall length of stay in the hospital for the same diagnosis is increased by about a day. What we found when we started moving people up, even if there is no bed, just moving them to a hallway, is that we were able to reverse that and reduce the length of stay by about a day. I'll talk about that a little more. If you're boarding patients and your emergency department's full and you're backed up, that leads to more walkouts of patients leaving the emergency department. We find in our area that if we look at those walkouts, about the same % of those patients need admission as the people that remained. So it's not just people with minor problems that are leaving. Some patients, and they'll tell you this, I was too sick to wait. Now that's crazy. Hospitals in the United States are monitored by an organization called the Joint Commission. And if you do something really horrible and terrible to someone, it's called a sentinel event. And that gets reported to the Joint Commission, and they come and investigate what happened, and you're supposed to fix it. Well, of all the sentinel events in the United States, the emergency department is involved in some way in a half of those, and a third of those, crowding and boarding, are involved in the person's problem. also in the United States, physicians, and I'm sure here too, physicians and nurses are harmed, but the malpractice incidence frequency in the United States, if we divide that up by was the patient that came to the emergency department seen within 30 minutes or took more than 30 minutes before they had their first contact with the doctor. If it's more than 30 minutes, the incidence of my being sued by the patient is increased by a factor of 5-fold. Goes from 1 in 25,000 to 1 in 5,000 by making them wait. Our nurses get overwhelmed with all of these patients, with the emergency department volume, plus now the additional inpatient volume. I don't know if you can get additional nurses to come to the emergency department when you're boarding patients. We certainly can't. They're not extra ones sitting around waiting to be called. And the last thing is we know now from some very good research that crowding and boarding causes death. And this is not just the anecdotes of someone sitting in the waiting room waiting to be seen, and then boom, they drop dead in the waiting room. There were several studies, a couple out of Australia, that asked the following question. They looked at patients showing up to the system when it had capacity versus when patients came into the system when there was no capacity. And they looked at the 3-day, 10-day, 30-day mortality because they wanted to ask, if there are delays in care, then are there downstream consequences, not just the deaths in the emergency department. And these are a few of the studies. I'm not going to go through them. But as you can see, this compares the death rate in the hospital for patients when they come in when there is capacity versus when there is not capacity. This is a very, very significant difference. It's about a 30% higher mortality rate if you come in during those times. You'll notice also here that if you come in on a weekend with an MI or a stroke, you have about a 5% greater chance of dying from that than if you come in during 9 to 5, Monday through Friday. And we'll talk a little bit more about that. We did a study at our institution that asked the following question. Let's look at how long patients board in the emergency department and see if there's any change in their mortality rate as a function of how long they sit there. So people who got upstairs in less than 2 hours, the mortality rate was 1.2%. If they waited in the emergency department for more than 24 hours, it tripled. It went to 3.8% just from boarding. And it had a bunch of other adverse effects too. There's a second problem that relates to all of this too, that has to do with having a 9 to 5, Monday through Friday hospital. Is this the way your system runs here? It's pretty much the same as in the United States. A lot of our, like Macy's or clothing stores, they're open 7 days a week, but the hospital is open mostly 5 days a week. And there's been a number of studies that have looked at the consequences of this, and I'll just show you a few papers. I'm not going to go through them, but they look at the mortality rate for MI, for CPR, for stroke, and what the difference is between weekends and weekdays, and the same number keeps coming up over and over again, about a 5% increase in mortality if you come in during off hours. So do hospitals provide lower quality care on weekends? See. So what's the solution? You can look all around, you look outside, but sometimes the solution is right in front of you or right behind you. So again, this assumes that you have the system that you're using is working well. Is that if you had the capacity, people would get into the emergency department, they would quickly be seen, you would quickly be able to get your x-rays and your labs and all of this stuff. But for capacity issues for the institution, because if you're boarding admissions in the emergency department, this has nothing to do with the emergency department. This has to do with the institution. It's an institutional problem, and it needs an institutional solution. And those solutions go in two directions. One is how do we create capacity? And the second is, no matter what you do, there are times when you have failure. So what do you do about the lack of capacity during those times? So I wanted to describe, at least in the United States, what hospitals were like back in the 1960s. 95% of the patients that were in the hospital were elective admissions. It was a very nice, easy pace. If you had gallbladder surgery, you might be in the hospital for 3 weeks. The average length of stay was about 10 to 12 days. So it made sense at that time to run a hospital 9 to 5, Monday through Friday, with a skeleton crew on evenings and nights and weekends. If I fast forward to a day of tragedy in New York, 9/11, the hospitals were 100% full that morning. By noon, 20% of the inpatient population had been discharged in anticipation of expecting a large number of critical patients, which was never realized. But they didn't fill again the next day. It took them about 3 to 6 months to fill back up again. And what that suggested is there's a lot of fluff, there's a lot of softness in this capacity issue that we really could do something about. So now let's look forward to today, 2014. We're not talking about 1964 when 95% of the patients were elective. Now in the States, 60 or 70% of the patients are emergency admissions. So the elective admissions are much, much, much smaller now. And as you know, there's just as many patients admitted from the emergency department on a Saturday or Sunday as there is on a Tuesday or Wednesday. There's really no difference. So how do we run our places now compared to 1964? 9 to 5, Monday through Friday, with a skeleton crew on evenings, nights, and weekends. In my institution, during the weekday, in the evening, our radiology department needs 3 nurses in order to give contrast for CAT scan studies. You know how many they need on weekends for the same volume? 0. How? Through a process that we call magical thinking. So this is my friend Eugene Litvak and Don Berwick, who was director of CMS in the United States. They were asked to come to Boston Medical Center. This is about 15 years ago, because Boston Medical Center had a problem. Their emergency department was filled all of the time. They had boarders all of the time. They had a huge number of walkouts. 8 or 10% of their patients left without being seen. They were always on ambulance diversion. Shame on that emergency department. It needed to be fixed. So they came and they looked. And this is what they found, is, you know what? The emergency department is, although you don't know if there's an emergency showing up a minute from now, you do know that, for instance, at my institution, I know every day we're going to have 50 admissions from the emergency department. Sometimes it's going to be 60, and sometimes it's going to be 40, but it's not going to be 2, and it's not going to be 200, and yet, do we prepare for those 50? No. It's like each day is a brand new day. You wake up and go, oh, I'm so surprised. There are admissions from the emergency department. But what they found was, even though this was all random, it was very predictable. You would get 50 patients a day, and you should plan for them, believe it or not. The elective admissions, however, you can control. You can tell them, come in on a Monday or come in on a Thursday. So they looked at that, and what they found was that it was the elective admissions that were creating capacity issues, because everybody wanted to bring their patient in on a Monday and do the procedure. And then later in the week, nobody would come in. So what they did was that they smoothed out the elective cases at that institution. And guess what happened? Their boarding in the emergency department went away. Their capacity problems went away, and their walkouts decreased. Their ambulance diversion went away. Another story, Cincinnati Children's Hospital, one of the busiest pediatric hospitals in the United States. They have a huge volume of cases, a huge backup, so much of a problem that they had the architectural drawings to build a 100-bed tower at a cost of $100 million. While they were in the midst of looking at building this, Dr. Litvak came and looked at their surgical scheduling, their elective scheduling. They smoothed it out, and this is what happened. They canceled the building. they were not only able to take care of the volume they had, they increased their volume by about 15%. They were making $130 million more a year in the same capacity without having a capacity issue. So by being able to provide that, now 100 less beds meant that they didn't have to spend the $100 million, and it didn't have to cost them $100 million a year because they wanted to run the place 9 to 5, Monday through Friday, instead of doing a little bit better. So I'm going to pick, of course it's not my institution, I would never talk about my institution, so this is institution Stony Woney that I want to tell you about. And they asked the question, well, do we have a problem? No, we don't, because we schedule things carefully and there's no problem at all with it. And at this institution, it's a 600-bed institution, and I want to ask the question, if we're full all the time, should we stay at 600 beds? Should we go to 700 beds? Or let's do something really crazy and go to 500 beds, which doesn't make any sense at all, but I'm just going to throw that in because I like to throw in stupid ideas. Oh no, there's no need for help here. And at this institution, this is the number of emergency admissions, and this is the number of elective admissions. And if you put them on top of each other, as you can see, these are the emergency admissions, and it's pretty much the same Sunday through Saturday. Whereas the elective admissions, there's this big peak Monday and Tuesday that starts to drop off. Here, if you just looked at this, these are the surgical scheduled admissions, which according to this institution, they already have a smooth schedule. They don't need help. They already are perfectly smooth. This doesn't look like a 5-day-a-week institution. It looks like a 2-day-a-week institution. And then they sort of show up for a half day, to Wednesday, Thursday, and Friday, and then everybody's gone on the weekends. So and what happens is the operating rooms are overwhelmed on Mondays and Tuesdays. You have to pay for overtime, bring extra people in. And on Wednesdays, Thursdays, and Fridays, they can sit around and talk about how busy Monday and Tuesday was. And notice how busy it is on the weekends. You go from 300 cases to 38 cases. Is there an opportunity there for capacity? So this is also discharges by day of the week, and you can see that on Saturday and Sunday, far fewer people get discharged compared to the other days. The weekend effect for discharges is so much that if you look by day of discharge, the average length of stay for a patient, if they went home on a Saturday, was 3.9 days. If they were discharged on a Monday, their average length of stay was 6.6 days. So because nobody wanted to do anything on the weekend. So here's the data on admissions from that hospital, and if we were to smooth out Monday through Friday, that would average 97 patients a day. If you smoothed it out through whole 7 days, then that would come out to 86 patients a day. What does that mean in terms of capacity for this 600-bed hospital that's full all the time? If you smooth them across the weekday, this 600-bed hospital that's now building a 100-bed tower would need 560 beds. And if you smoothed it across 7 days a week, then but it had no effect on length of stay, which of course you would. But if you smoothed it across 7 days a week, remember I thought that crazy idea of having 500 beds instead of 600 beds? That's what you would need. You would need 500 beds to provide the same care to the same people. You wouldn't have the weekend effect of the increased mortality rate, and you'd be matching the hospital's industry to what the patient's needs are. Do we do that? No, we don't do that. Well, we do it in emergency medicine. OB, obstetrics has started to do it. Anesthesia is there 7 days a week. Our hospitalist services are 7 days on, 7 days off, so they're there 7 days a week. And we're trying to move to push other services so that they're available to the same degree on weekends. By doing so, we might be able to substantially decrease the capacity issue and have plenty of capacity to go around. The other thing, I don't know if this is an issue in Chile or not. On average, The doctor writes an order to discharge the patient around 1 o'clock in the afternoon, and the patient leaves an average of about 5 o'clock in the afternoon. And we always blame that on the patient, of course. But if you actually, if emergency department volume grows through the day, it peaks in the evening. That's when you have all your admissions. So wouldn't it be nice if you could get people out in the morning so you could be bringing them in the afternoon and the evening? How much does that impact on boarding? Over 95% of your boarding would go away if you just simply did that. If you had got people out before noon, out of the hospital. So you want to make space for this lady? I don't know if you allow smoking in your hospital, but the answer is not to build more beds. It's to use what is clearly a huge amount of wasted capacity. So you want this, if you smooth things out, that's the solution to creating capacity. But what if we have no capacity? What if you've done everything right, but there's just been a real bad stretch? It's flu season, they got a tremendous increased volume. What do you do when you actually run out of capacity? Well, the solution in many, many places is just simply to add more and more and more boarders in the emergency department. Why? Because we are infinitely expandable. And what about staffing? Our staff, because we're in emergency medicine, we can take care of more and more and more patients and do it without ever having an error because we are amazing. So how do we fix the problem? We fix it through magical thinking. Or let's have a meeting. Let's have a project. Let's put lipstick on the pig to make the pig a little more attractive. So for instance, at my institution, our average discharge time was 5 o'clock. The orders were written at 1, patient went home at 5. So for 5 years, we had meetings every month. Everybody came to the meetings. We had projects. We are committed to moving that discharge time earlier, and we did. After 5 years of effort, we started with an average physician order time of 1:15. When we were done 5 years later, the average discharge time was 1:05. Wow. Lipstick on the pig. So you can see failure coming. You want to have a plan for it. So here's the question I would ask to anyone who wants to pretend to be sane. We have all these areas in the hospital, and they're all full. There's no more beds available. And we now have 20 admissions that we have to put somewhere. And we have 10 different places we could put them. And all 10 of those places are saturated. So how do we distribute these patients, these 20 patients to these 10 units? Now, someone outside of medicine would say, that's a dumb question. You would put 2 patients on each unit. But what's our answer to that? Oh, no, let's put all 20 patients in 1 unit. Oh, it happens to be the emergency department, but that's the rational answer to this question. And that's sort of a little bit crazy, I think. Again, I don't know what your practice is like here, but at my institution, nurses are not nurses. Nurses are emergency nurses, or operating room nurses, or oncology nurses, or cardiac nurses. And when you put a patient on a cardiac floor that's a cardiac patient, they now have the expertise of that cardiac nurse and the cardiologist. Whereas in the emergency department, they get the expertise of whoever can get to them when they scream, or their family screams that they've quit breathing. Oncology patients in the emergency department is a terrible place to have them. Or in people with infection, there's no isolation room for them upstairs, so we keep them in our hallways. I love that. So what to do? You can do nothing. You can keep your head in the sand and do absolutely nothing. Or what we said was, what the hell, let's move them upstairs. And some people love this idea, some people hate this idea. Let me explain explicitly what we ask our staff to do upstairs when we have boarding problems and we need to move patients up. We actually move them, they're in our hallway, we move them to a hallway upstairs. We ask each 30-bedded unit to take 2 additional patients. So they go from 30 to 32. They're not going from 30 to 50, they're going from 30 to 32. And because it's a small increment, it has worked very well without difficulty for them or the patients. So some are very, very enthusiastic about the idea, and some you really just sort of have to drag to get them to even sort of entertain the notion that that may be what it is. So this is my emergency department. Look at the people I have in the hallway. How did this lady get here? This lady got here because she was in this room. I saw her. She was having belly pain. We started a line. We drew bloods. I move her out into the hallway so I can bring the next patient in and see them so that people don't wait, because I want to get things started on them. And they don't own the room unless they need to for some reason, like they're in VTAC or something like that. But otherwise, we move patients in and out. So we have them in our hallways. So once you have them in a hallway, what's the difference if they go somewhere else? So here's more of our, we have very strict fire codes in hospitals in the United States. And so you would ask, well, isn't this a violation of fire code? And it is. But we have a very strict rule in our emergency department that no patient is allowed to catch on fire. And that solves it. So here's more scenes of mayhem here. And this is what it looks like when you move them to a hallway upstairs. It's much quieter. It's much more peaceful. They get warm food. If they stay in the emergency department, they have to be a hunter and a gatherer in order to get any food. And there'll be a curtain around them. We've done this so that there's a curtain around them and this sort of thing. When we've done this, we ask the patients, did you prefer being in the hallway in the emergency department or prefer being in the hallway upstairs? And 90% of them said, please move me upstairs. 10% smoked, so they wanted to be able to go outside and have a cigarette, so they wanted to stay down in the emergency department. So we've shown that it lowers mortality rates, the length of stay is shorter, and we're not asking the inpatient units to do that much. So let me show you how this works at my place, and then I'm done. This is one Monday. You can see we're starting to get really busy. This is an open curtained area, and this is our critical area where the sickest patients go. And now between two curtains, how many patients should be between a set of curtains? One. How many people are between this two sets of curtains right here? 1, 2, 3. Why are there pictures being taken? There are pictures being taken because I'm the director of the emergency department. I was not working this day, and I came down because this patient vomited on that patient. So they wanted to see the director. And so I came down and I said, yes, indeed, he vomited on you. So anyway, it's getting busier and busier and busier. We have a gunshot wound to the pelvis come in. We have a guy with a dislocated ankle. There's a 4-year-old asthmatic right across from these two patients watching all this. He's thinking he's watching the coolest television show he's ever seen in his life. And talk about crowding. Call a trauma code. You have so many surgeons come down at our place, there's no more oxygen in the room here. So everybody's busy doing as much as they can. This is one hallway, fully loaded with one of our hallways in the emergency department, fully loaded with patients. Here's another hallway, fully loaded with patients. One thing I always like to do is put these patients out in the hallway where people come into work, like especially our administrators, have to walk by the patients. So as they're walking by, you know, they'll get grabbed by the patient. Oh, feed me! I need to go to the bathroom, help me! So that works very well. You know, we're putting them anywhere that we can, just hanging them anywhere. That's the person that's asking to be fed. And here's staff coming down. They're moving as many patients as they can upstairs to give us space to work. And the end result for this day, it took 28 minutes on average for a patient to get into a room and another 7 minutes for the doctor to get with them to see them. And that is our goal, is to make sure that we can provide care to emergencies and that the inpatient services can provide care to inpatients, and we're all in this together. And on that note, I think, well, when you see patients like this, and you see patients that, for instance, have a tree trunk in their butt, or severe burns, or knife in the face, it's obvious that we can't be taking care of boarded admissions because we're too busy taking pictures of our patients. So, oh, that's just those of you that can read plain films, you can figure out what this is. And so that's it for me. Thank you very much, and we're going to the next.